So we'll give 1 hour for Professor David, and I'll take 40 minutes with a rapid, a fast case presentation with one of our eminent colleagues, Dr. Ahmed Shihab, with a good history he's taking, and we'll leave in 2:30. Now, Professor David Butler.
Well, first, I want to thank all of you for coming on a nice day. Hopefully not just for the free lunch. More importantly, I want to thank you for what you do for your patients and their families. I've been an academic psychiatrist since the very early 1980s. I finished my psychiatric residency in 1981. And I've been in the academic side of things. As a dean, as a department chair, as a provost rector. And I've always admired clinicians who don't get to travel around the world and do talks and go to conferences and get nice bags when you go to these things. Every day you were there for your patients and you were there for their families. And that, I thank you for them, because sometimes they forget to thank you, but I'm sure they appreciate what you do for them. What I'd like to do today is share with you, and I apologize, I don't speak Arabic. Not even a little bit. Shukran, 1 or 2 words. So if you don't understand, or if I'm speaking too quickly, let me know and I'll slow down. If we do questions and answers, I will ask Professor Sumir that we do the questions in Arabic, so maybe you'd be more comfortable asking the question in Arabic, and unfortunately I have to answer in English. So what I want to talk about today is something called lifestyle psychiatry. Has anyone ever heard that term? Maybe lifestyle medicine. You hear that a lot in the West. Lifestyle psychiatry, although it's been around as long as the pyramids, in concept, it's a new way of thinking about and treating the patient. It's not a new medication. It's not a new form of psychotherapy. But what it is a way that we should understand and maybe treat all of our patients. There's a center for lifestyle psychiatry, actually, that's relatively new in the United States, in a university at Stanford University, which is a big university in California, where I live. There's been 1 textbook written. We're actually running the 2nd textbook. But what I want to do today is share with you what lifestyle psychiatry could mean for you in your work as a mental health professional, in the way you think about and the way you treat your patients. So this is not about learning something to pass an exam. This is about hopefully sharing something for you in a way to think about caring for your patients in a way that will improve their quality of life. And that's what we all try to do as clinicians and providers. So I always forget that iPads do not work particularly well in hooking up with Egypt, but we do this without the slides. I know the material pretty well. Lifestyle psychiatry has 6 pillars. Pillars are like posts. 6 things that we want to.
في مشكلة في الإنجليزي يا جماعة؟ لا. كله. حضرتك؟ أخصائيين نفسيين، كله دكاترة، كله تمام. ففي أي حاجة بلغوني وترجمها في ساعتها. 6 pillars يعني الدعامات ال6 اللي بنشتغل على اللايف ستايل سايكاتري.
Each pillar is important to assess with the patient, but then have that be a part of your thinking in developing a treatment plan, a treatment strategy. So the first pillar of lifestyle psychiatry is exercise and activity. As it turns out, there is a great deal of research, well done research, demonstrating that regular exercise is important to maintain health and mental health, and is an effective treatment strategy. I did a study at one of my old universities many years ago in a inpatient psychiatric unit, mostly chronic schizophrenic patients. And we brought in an exercise program onto the unit. This was not done very much in the United States back then. And what we found is the patients did much better. They required less medication. They were calmer. They were able to respond as if we had raised the dose of their medication. Exercise has been used in addiction medicine for many years. It's probably as effective, if you look at the research studies, as effective as most antidepressants. If you look at the effect size, which is just a mathematical calculation of how did the treatment work. So the effect size for a regular exercise program is actually higher than virtually every antidepressant on the market. That doesn't mean that antidepressants aren't important. I'm trained as a psychopharmacologist. I'm the head of the section of psychopharmacology for the group for the advancement of psychiatry. So medications are important when used appropriately at the right dose. But exercise, one of those pillars, is not only important to maintain health, but can be a very effective treatment. Now, the one thing that I've been lecturing about over the last year or two is that it's not only exercise, but it's enjoyable exercise. If we tell the patient to do exercise that they don't like, we tell one of my female patients, go out and lift weights, that's good exercise. I don't like to lift weights. So part of the pillar, part of positive psychiatry, is finding an exercise program that someone will enjoy. People say, well, what's the best exercise? And my answer is, the best exercise is the one the patient will do. What's the best shoe? If you wear a 42, the best shoe isn't a 38 or a 44. The best shoe is the one that fits you. And what we try to do, and what we're doing now in mental health, is personalized or precision medicine, not just using the same size for everyone, but using technology to understand what's best for this patient. In medication, we try to find the right dose. In lifestyle psychiatry, for exercise, what will the patient do? If they enjoy it, they'll do it. If they don't enjoy it, they'll figure out a way to not do it. And it turns out, if they enjoy it, they get better results. So we do brain imaging work. We have very sophisticated brain imaging machines where we can look at the way the brain is talking to itself with high-level magnets, a 5 Tesla magnet. These used to be researched, not so much now. But we can look at how the brain is working, not just like taking an X-ray or a CAT scan, but literally looking at how the brain is functioning. And it turns out, when you're doing exercise that you enjoy, the brain responds in a better way. So exercise and activity, first pillar. The most robust, the largest amount of data demonstrating this works well. Young, old, women, children, even a very old person sitting in a wheelchair can do light exercise. What we want to do is keep the body moving, elevate the heart rate, keep it up. In the US, walking has become a very important part of health now. They say if you're in good health, that you should try to walk 10,000 steps a day. Most people walk, particularly if you're walking the streets of Cairo, you're probably walking that much anyway. But it turns out you don't have to always walk 10,000 steps. 1,000, 2,000, 3,000, they have a health benefit. The more you do, the greater the benefit. So even a small amount of exercise is better than no exercise at all. And it's happening in the brain, not just in the heart or in the legs or arms if you're lifting weights. And any type of exercise can be beneficial. We just finished a study looking at experimental rats. And it turns out when you take rats and there's a special way you can have them run on a treadmill. And we escalated that. The paper was just published 2 weeks ago now. And it turns out for rats that regular advanced exercise changes CBD receptors in the brain. So exercise has a direct effect on patients with addiction. And it doesn't make any difference what the addiction is to. Hashish, anything. Because it's happening at the part of the brain that we know is associated with all addictions. That dopamine pathway. So exercise is the first pillar. And what we need to do is not just to tell the patient, well, you should go out and get some exercise. What we need to do is sit down with the patient and say, we know exercise is very important for your physical and your mental health. What type of exercise do you enjoy? I don't know. Patient maybe doesn't have. I had a patient many years ago. I was at the National Institute of Mental Health in the United States outside of Washington. And we were studying behavioral endocrinology. We were studying women, the effects of kind of endocrine system on mood and behavior. And we had the women would come in for 4 months and we would do studies. And at the end of 4 months, this is many years ago, a woman came and she said, well, Professor Baaron, you've talked about exercise. What type of exercise should I do? And I was young and not very smart back then. And I said, well, I know that you have a swimming pool in your compound. Swimming is wonderful exercise. Why don't you try to swim 3 or 4 times a week? And she walked out. 2 weeks later, she came back for a follow-up visit. She walks in like this. Her voice was very low. Her head was down. I said, oh my goodness, I missed the diagnosis. This woman was depressed. And I said, what's the problem? And she said, Professor Baaron, you worked with me for 4 months. Every day you saw me, we did the studies. And she said, I asked you one thing. What exercise should I do? And you answered my question. And I could not tell you that I hate to swim. I'm afraid of the water. And I haven't been in the pool since we talked 2 weeks ago. And I said, shame on me. I was not a good doctor. I should have asked you, now again, a long time ago, this is over 40 years ago, I should have asked you, but let me try to make things better now. What type of exercise do you like to do? And she says, well, I don't like to run. I don't really like to walk. I don't like to ride a bicycle. I feel uncomfortable. I said, it's okay. What type of things do you like to do that gets your heart rate up? Maybe gets you a little bit perspiring. And she looked at me kind of sheepishly and she said, I love to dance. I said, that's good. Dancing is very good. And she said, but there's a problem. I said, well, what's the problem? And she said, my husband hates to dance. So I looked at her, I pulled out my prescription pad, and I wrote her a prescription. And the prescription said, dancing 3 times a week for a minimum of 30 minutes, with or without husband. And she laughed, but she left. And she came back a month later, smiling, happy. I said, I hope she's not hypomanic. And she came and she sat down and she looked wonderful. And I said, well, I'm glad to see you smiling. You have such a beautiful smile. Tell me what's happened. And she said, I showed the prescription to my husband. And he laughed. And we went out and we signed up for dancing lessons together. And now we go out. Not only do we take dancing lessons, we find clubs that have dancing. And she said, our marriage has never been better. I dropped a few kilos. He dropped a few kilos. And things are wonderful. And I said, that's good. So exercise, if it's fun, will be effective. And the only one who can tell us what's going to be fun is the patient themselves. So exercise is the first pillar. Then we have the 4 S's. So the first is sleep. Now, we all know that it's good to get a good night's sleep. We feel better. But sleep is one of the most powerful biological interventions. During deep sleep is when the brain flushes away certain chemicals that lead to dementia, that lead to memory impairment. There's something called hyperphosphorylated tau. It's this little thing that gets in the brain. And if it doesn't get flushed out, it drops in to the brain and it sits there and it leads to changes in cognition, in memory. And there's no medication that can flush that out the way restful sleep. Now, I'm not talking about a 10-minute cat nap, but getting into, we know sleep goes through cycles when you go through a night's sleep. So a good power nap. Professor Samir is the king and expert of power naps. He works so many hours, but he knows, oh, I've got an hour. He takes a power nap, he's ready to go. He's the master of it. He's learned this over the years. But sleep is a very, very important part of mental and physical health. In fact, during the war, the way they would torture people to give up information, they didn't have to pull out their fingernails or do the things you see in the movie. They would keep them awake. They would sleep deprive them. Because after about 2.5 to 3 days worth of sleep deprivation, you become psychotic. So sleep is a very important part of not only maintaining physical and mental health, but also treatment. So we need to assess what is the quality, not just the quantity. We know quality is kind of how much. The quantity is kind of how good is it. So it turns out, some people say, oh, I only need 2 hours or 3 hours of sleep. No, that's not enough for anybody. Teenagers might think they can get by with that, but not so much. Because sleep will exacerbate every mental illness: anxiety, depression, psychosis, personality disorders, substance abuse. We know that alcohol and other drugs, people say, oh, I drink. I know not as much alcohol here although I see many more bars in Cairo than I saw when I first came here 20 years ago. But alcohol, people say, yes, I fall asleep. It knocks them out, but it's not quality sleep. The brain doesn't flush out those toxic substances that form. So how do we determine if a patient is having good quality sleep? How do we know? Do we have to send them to the university and get sleep studies done? No. The best way to assess the quality of sleep is first, how many hours are you sleeping? If someone says, I'm only sleeping 1 or 2 hours, can't be quality. If someone says, I'm sleeping 8 to 10 hours, that could be, but the most important question, what I want you to all remember when you're asking your patients about sleep: do you feel rested when you get up in the morning? If someone says, well, I got into bed at 10 o'clock and I got up at 7 o'clock or 6 o'clock, all right, 8 hours of sleep. How do you feel when you get up in the morning? Oh my gosh, I need at least 2 cups of coffee and a cold shower just to wake up. That's not quality sleep. If you have good quality sleep, you wake up, you feel refreshed. Do you ever see the commercials for mattresses? Now, I haven't seen a lot of not a lot of the commercials here in Egypt, but always for a mattress, the commercial, they always have the person getting up and feeling like they're ready to go out and run a marathon. Oh, I got such a good night's rest. That's good quality sleep. So it's a simple question. You don't need a psychometric instrument. You don't need to put all kinds of leads on someone. You don't need to draw blood and measure. You need to ask one question. Do you feel rested in the morning? All of us have a night, maybe we ate something that didn't agree with us. Everyone has a night where you don't feel so good. You didn't get a good night's rest. Stress, anxiety, we know these have very, very negative effects on sleep. Right? Anxious people have a hard time falling asleep because their brain's going so fast. We call it the busy mind syndrome. They can't turn it off. They've got all that, they're worrying about their kids, their relationships, the money, the work, everything. The brain is just full of thoughts that it won't allow them to calm down, to allow the brain to go into sleep. Depressed patients, as we know, sometimes will fall asleep, but then they wake up after an hour or two. They have what's called middle or terminal insomnia. It means they wake up early, but they're not refreshed. So they might be in the bed for 8, 10, 12 or more hours, but they're not refreshed. They get out of bed and they're still tired. So depression affects sleep in a different way, but virtually all of the, what do we see from our manic patients? What is one of the first things we ask a manic patient? Are you able to sleep? Manic patients, right? They go a day or two without sleeping, but then they crash. Because the brain must have restful sleep to function. We deal with patients who have problems with their mental health and their physical health, but their mental health. Sleep is critical. We can't overestimate how important it is. If we give a patient medication and they're over-sedated, that's not good. If we give them a medication and they're overactivated, a stimulant for ADHD, and they can't get to sleep, that's not good. So sleep is one of the really critical pillars. Pillar number 2. The other pillars, so 2 down, 4 to go. We talk about social relationships and connectedness. We all know that human beings, we are social animals. We need each other. When people don't look for interpersonal relationships, we call them autistic, we give them a diagnostic label. It turns out the Surgeon General, the past Surgeon General of the United States, said the greatest public health, not mental health, but the greatest public health risk in the United States was people feeling lonely and isolated. This was particularly true during COVID. When people were isolated, they couldn't get out, they couldn't intermingle. So our connectedness with our friends, our family, our coworkers, very important. So social relationships, when people feel isolated, and you can be in a big room of people and still feel isolated. Or you can be with one other person and feel connected. So connection isn't about being in a busy room, standing on the street corner and many people waiting to get on the bus. It's that sense of feeling connected to people you care about and people who care about you. We see this in the military oftentimes. And I've done a fair amount of work with different armies and militaries all over the world. And what soldiers will say is even the stress of being in war, in conflict, what allows them to stay together is that sense of connectedness to their brothers and sisters. We were just on lovely holiday with Samir and his friends, and I don't speak Arabic, but I can sit back and watch them, and they're all connected. They're genuinely having fun. They're enjoying each other's company. They're improving their mental health. So social connectedness, we have to ask, oftentimes psychiatric patients, we know the prejudice. If someone acts strangely, they talk to themselves, maybe they act bizarrely. Our patients are at higher risk to be socially isolated. Oftentimes even their own families. Families are embarrassed. Maybe they feel this was punishment from God, that they got their psychotic illness or whatever they might have. So social connectedness, very important. And we need to ask about that, and we need to help our patients. One of the things I always did when I was very young in my career, I was running a psychiatric hospital. We tried to have the patients do activities together so they could try to connect, not just by themselves, but something where they felt a little more connected, not isolated. The next S, dealing with stress. Now, people say, well, how do I get rid of all stress? And I say there's only one way that I know to get rid of all stress. And that's to die. Because I don't think we feel a lot of stress when we're dead. At least I hope not. So stress is a part of life. And in fact, certain levels of stress allow us to perform better. When we feel a little bit of stress before we go in for examination, before we go in for a job interview. I deal with many athletes from around the world. Before Olympic athletes, before they get up to compete, that level of stress takes them to that higher level. We call that eustress, good stress. But when stress continues, it becomes distress, bad stress. That's when people start having symptoms related to stress. Maybe their sleep, they can't relax. They've got racing thoughts. Problems with their stomach, maybe their heart's racing. We call it stress hormone. Cortisol is the one hormone that it's in the base of the brain, and it kind of comes down through the hypothalamus, the pituitary, the adrenal, gonadal axis, but stress hormones. So the body reacts to stress. A little stress can be helpful. Understanding what toxins are they taking into their body. Could be tobacco. Actually, too much refined sugar. White sugar is that. Now, we all put a little sugar in our tea. As I've gotten older, I put less to try to keep the tummy from getting like this. But we know that toxins come in many different forms. So, stress management and helping the patient to assess and to decrease toxic substances that are going into their bodies. So there are 4 S's. The last of the 6 pillars is nutrition and hydration. So they used to say, we are what we eat. That's not probably totally true, but it's not totally wrong either. If we eat a lot of saturated fats, animal fats, for example, not only does it get the tummy fatter, but the coronary vessels in the heart get fatter. And that's why people have heart attacks. The vessels around the kidney. So diet becomes very important. Now, unfortunately, we see a lot of fad diets. A fad diet is sometimes, many different. In the US, one of the most popular diets, shown to be one of the healthiest, is a Mediterranean diet. Vegetables, fruit, fish. Not a lot of butter. Butter or saturated fat, so unsaturated fat. So we know we've got kind of good fats, the high density lipoprotein, HDLs, and we've got the bad fats, the LDLs, low density. Turns out saturated animal fat particularly is not particularly good. Butter. Olive oil, very good. Olive oil can actually lower the LDLs and raise the good fats. Hydration. you live in a climate where it's warm a lot of the time. People perspire a lot. Too many people do not drink enough water. The body needs water to function. Our patients, oftentimes when they're on medications, need even more water. And although coffee is a nice beverage when you want it, coffee, it turns out, is a diuretic. They say you don't really buy coffee, you only rent it. You drink it, but then you give some of it back in an hour or two. So it's important for our patients that we make sure they're having a balanced diet. I'm not a big fan of these, starvation diets and this diet. I think we need to let the science tell us. What we do know is a diet that's high in fruit, vegetables, proteins, lean proteins like chicken, fish, lean meat, not fatty meat. I mean, most of the time, when I come here, I probably eat healthier when I'm in Egypt than I'm eating when I'm in Los Angeles. Because the diet, unfortunately, some of the foods that we like the most are some of the most unhealthy foods. Fast food, McDonald's, pretty high on the list, as some people might almost say it's toxic. Yet, who doesn't like a Big Mac with some French fries? If you're mildly hypertensive, we know the importance of salt if you're on lithium. Because if you change the salt intake, you literally can change as much as 30 to 40% the lithium level. Yes, please.
دكتور سمير ممكن تترجم له ان محشي ورق العنب يعني ريليتد النقطه دي ان هو خضار ورز ان هو يعتبر دايت حلو جدا واحنا سبيشال فيه بنعرف نعمل محشي ورق عنب كويس.
يعني ايه محشي ورق عنب؟
ورق العنب محشي
She's talking about the leaves with the rice inside.
Oh, yeah.
Like she does.
Yeah.
She's telling it one of the best Egyptian food, and it's good for lifestyle.
Very good, because grape leaves, low in fat, that's good. And made with olive oil. Don't make them with butter. But olive oil is very healthy. In fact, there are people who I know who are dear friends of mine, even I consider my brother, who will have a little bit of olive oil with hot water in the morning. That's a good, healthy way to start the day, because olive oil is actually one of the things that's very healthy, whereas butter and lard, lard is made from animal fat. Very unhealthy. That's high in what we call saturated fats. They stick together, they clog up in the arteries throughout the body. Sometimes giving the patient a pill, well, why should I take your pill? Why don't I take my pill? Because I know my pill makes me feel better. So I'm not against medications. I think medications are very appropriate to treat specific symptoms. But we know that there's not any pill that cures addiction. They can help with the symptoms. Medications play a very important role when used properly. I believe for all of our patients, we should consider how can we understand them from these pillars: exercise, sleep, socialization, substance, stress management, diet, and nutrition. How can we make that apart? Because I think when patients feel engaged in their treatment, an active patient versus a passive patient, I go in, the doctor tells me what to do, or he or she gives me the medication or a shot, I think engaging people in their treatment is an important part of treatment. When the patient feels like my doctor cares about me as a person, not just someone to fill out a prescription. I can tell you, Professor Samir, and I'm with him a lot, his patients call him all the time because they know he's there for them. And that's what makes him a very special doctor. The patients have a sense of confidence, not only that he's a good psychiatrist and he's knowledgeable, but he genuinely cares about them. That's social connectedness. And I believe, hopefully, as we move forward with this, this will take on new meaning for the next generation of psychiatrists, psychologists, mental health professionals at all levels. because we're all responsible for the health, safety, well-being, and quality of life for our patients. As a sports doctor, as a former sportsman myself, no team wins by one good player. You can have the world's greatest goalkeeper. If you don't have good fullbacks, you're going to lose. You can have Messi on the front line. If you have a bad goalkeeper, you're probably not going to win. The winning teams work together for the good of the team. For us, we work together for the good of our patients and for their families. So let me stop here, maybe some questions and comments. Again, I want to thank all of you for spending part of your day here, and maybe you have some questions or comments before we move on.
أي تعليقات أو خبرة شخصية أو أسئلة؟
Someone had a question here, gentlemen.
اتفضل يا بيه.
I want to ask about the practice in this model.
Could you see? I'm sorry, I couldn't hear.
Religious practice in this model.
Religious, spiritual. I'll call it. It's better to call it spiritual. Spiritual practice. الفرق ايه الفرق يا جماعه؟ علاقتك ب what you believe. Religious is
Laws.
إله أو دين، لكن spiritual اعتقاداتك. احنا مش متعودين على ده في مجتمعنا الشرقي، لكن ده بكلمك على البيبرز العالمية. He's asking about why don't you put one of the 6 pillars, religious or spiritual, relatedness?
I think spirituality is very important. When I talk about biopsychosocial, I used to talk about biopsychosocial and spiritual. Spiritual to me kind of fits into the connectedness. So we can connect to our friends, our families, but we can also connect to God or connect to a higher power. The 12 steps, right? 12 steps addiction, they talk about connection to a higher power. So I completely agree with you. I think spirituality or religion gives us a sense of purpose. We're here to serve something other than ourselves. And most religions, and I've had a chance to study a little bit in different religions, are much more the same than they are different. It's human beings that we try to make them different. We fight wars, but when we get down to a sense of being righteous and being good and being honest and being fair and having a relationship with the higher power, I think that's very important. Many people, particularly in the U.S., though, when they hear religion, they feel like it turns them off a little bit. Not me. But so what we do is we talk about this connectedness. And to me, one of the most important parts of being connected is being connected not only to our family and our friends and our coworkers, but being connected to a higher power. So I fully agree with you.
اتفضل.
Okay. So currently I'm asking, like, are those pillars could be applied to any patient in any state, regardless, like, how we could apply such approaches, or different according to the case?
The same for everybody. Now, how you might do it then, but those same 6 pillars, every single patient, unless they're comatose. If they're comatose, not so much. But if they're alive and they can interact, and that's why we talk about, so if you have an acutely psychotic patient, you still are interested in having them get some activity. We published a paper, it was on my slides here, about actually showing that it lowers psychotic symptoms just by a regular, enjoyable exercise program. The sleep, normalizing regular sleep, helping them deal with the stress, whatever that stress might be, watching their food intake, having them feel more connected, whether it's to other patients, their family members. I used to always like to bring the family in if we could. So it's those 6 pillars are the same for every conscious, awake patient.
So, yeah, I have 2 questions, particularly related to exercise. So
Yes.
First one, do you think difference between group exercise and individual exercise with regard to the
Yeah,
impact
yeah.
on mental health?
A very good question. So we've actually studied that. And I did a Fulbright in Malaysia. So I like working in low middle income countries because I'm always so impressed how people do so much more with so much less. We waste a lot of money in the US, and I've learned so much from my colleagues in low middle income countries who don't have the resources. So I did a Fulbright, and we went out into the jungles of Sabah in Malaysia, and we studied, and it turns out that exercise for most people done in a small group, they do a little bit better. Now, does it have to be that way? I don't think it has to be that way. One of the things, I had a grant in Oregon, which is on the western part of the United States, in a rural town. And we had elderly patients who we were able to get, there was a local swimming pool that was part of the community. And we had them do water yoga, water only this deep. But they would just get out, get some exercise and move, and then afterwards they'd go out and they'll have a cup of tea and talk about their grandchildren. So exercise can be integrated with social connectedness. I tell people, if you go for a walk, that's good. If you go for a walk and you're talking with your friend and you're talking about the football match last night or the chilly weather or the upcoming, then we can magnify. So there is some data to demonstrate that if you can do the exercise with someone that you enjoy, so it becomes social as well as the exercise. But even if they're doing it alone, the benefit's still there. So I tell people, if you can go out, join, if you can get a walking group and you enjoy that, or you can go out and play pickleball or tennis at the local, whatever it might be, or go for a walk with your friends, that you bring in that socialization piece. I think that's a little bit better. We've looked at that with women with breast cancer. Turns out exercise for stress reduction in breast cancer, it was better when they were able to do it in small groups as opposed to individually. Sometimes when they do it individually, their mind shifts to other things. When they're in a group, they can talk about something else. So it's a very good question. There is data to demonstrate small groups might be better, but doing it alone is better, way better than not doing it at all.
Yeah, thank you for the insightful answer. My second question is about the exercise. Do you think that there is a role for exercise in the management of psychotic disorders, or it's more in the neurotic disorders, if we can use this classification?
The first study I did that we published was the use of regular exercise in chronically schizophrenic patients. In an inpatient unit back in Philadelphia, where I trained. It's on the East Coast, just a little bit south of New York City. We did a study. We had a regular exercise, but we did it on the unit. I don't know if they ever had them. Did they have those Wii games? Like that Wii tennis?
Yes.
It was like, these were popular a number of years ago. We got the company to donate a bunch of those Wii tennis, and we put it on the unit, and it was part of breakfast, group therapy, Wii tennis. We built it right into the program. And then we had a control group where they could just sit in quiet, and then we were able to, and turns out some of them did much better. Less use of PRN medications. We're able to lower the dose. So exercise, absolutely, I believe. The problem is in the old state hospitals, they were on the unit. There wasn't really good place. If they would go out they would go out sometimes if they had a break during the day, and they'd just stand around or they'd smoke cigarettes. Not a good thing.
But do you think this could be traced back to the fact that they are doing it in groups, so this is related to the social connectedness, or more to the...
I think it's both, because we actually had some people who did it alone, who maybe didn't feel comfortable in the group yet. They did it alone. So I think what exercise does, it actually activates certain parts of the brain that help normalize. So and many people think, well, a schizophrenic or chronically psychotic patient, we got to wait till they're more stable before they can do it. I think as long as it can be safe, and I would encourage you to kind of put your heads together and think about what types of things can we do that's going to be enjoyable for the patient, but part of their regular day. We would actually have patients in the morning. We would do a thing, we would say, who can be the strangest dancer? Because some of them weren't good dancers, but they could all do goofy things. And I said, I'm the world's worst dancer. But what we would do is they'd just put the music on and they were doing what people would say, what is that? But they felt better. They were able to eat better. They were able to sleep better. So I believe, and I published this data, not in Arabic, but in English, that exercise, regular exercise, not just once or twice, 3-4 times a week on a regular basis should be an important part of treatment for all the patients that we see as mental health providers.
Thank you.
I would like to add something. If we do a group therapy, not of here and now or dynamic oriented group therapy for psychotics, you just do a social interaction. What the schizophrenic will get benefit of this? Schizophrenic or psychotics has no object relation. There is no others. It's only my narcissism. It's only me. No relatedness to others. That's why this loop of narcissism makes me psychotic. If we do a group and we interact, we read the newspaper, we talk together about the daily activities, this makes us schizophrenic to be oriented that there are others. Suppose or imagine that we are in the courtyard, احنا واقفين في الملعب, and we throw a ball together. This will make the relatedness, it will make the interactions, it will make the object relation. Beside the good benefits of reducing weight because of the medications and optimizing the cholesterol and so on. So the sports for psychotics is to have a new object relation.
Yeah, and just moving. You ever notice how when you sit around for a week, you don't do anything? You don't feel, the body is meant to move. And what I see with Tai Chi, now, do they do Tai Chi?
I don't know it.
Tai Chi is...
Taekwondo or...
Yeah, no, Tai
yoga.
Chi is, if you go to Asia, what you'll see is the older people will get up in the morning, they walk down, usually by the river, and Tai Chi is very slow, rhythmic movement. And if you watch it, and it's thousands of years old, the Chinese have been doing this for, it's not jerky like the movies, but it's slow and it's rhythmic. And if you watch them, every joint will go through movement, slow and easy. And that's very health promoting. The Chinese have known this for many thousands of years. So the body does better when it moves. This is why swimming turns out to be, it's my former sport, but it's a very good, if you like to swim, because virtually most joints, if you're the stroke, it's the shoulders, the wrists come through, your core exercise, your kicking, your head turns to breathe. So exercises that allow the body to move tend to be better as long as they're enjoyable. Did you have a question? Or
Yes.
comment?
Yeah.
This is the last question to start the case presentation.
Okay. My question to you, Dr. David, is for sleep.
Yes.
I noticed that you ask and advise many patients for promoting their sleep. What is like your one top advice for all of your patients that really works well for all your patients to enhance sleep, especially those who have addiction problems, those who have primary disorders that really affect sleep quality? What is like the main advice you give, and when do you expect like better outcome from those 6 pillars to work out?
Yeah, it's a great question. So when it comes to sleep, we know that there are many, many things that can affect sleep in a bad way. They have this thing called sleep hygiene. So one of the things we talk about is you probably shouldn't be drinking caffeinated beverages right before you go to sleep. Some people are very sick. And I love the taste of coffee. I'll eat coffee ice cream. If I drink a cup of coffee after 4 p.m., I'm up till 2 a.m. I'm just very sensitive to it. My wife can have a cup of coffee and be asleep in 10 minutes. So everyone has a different sensitivity to caffeine. So part of sleep hygiene is avoid things that are stimulating. If you're going to work out, do it a few hours. Don't go do a workout and then fall into bed and expect to fall asleep. The body and the mind need to calm down. We talk about if you're feeling very stressed, try to, before you get to sleep, is okay, what can I do? Maybe breathing, sometimes deep breathing, mindfulness, okay, I want to imagine myself breathing. Dealing with sleep is very important, but sometimes it's not so easy. What I tell my patients is, we know there are many things that can affect sleep badly. The use of drugs, when someone's detoxing, when they're coming off. One of the things I used to notice is I knew my patients were finally getting better when they started saying, my sleep's getting better. That could be weeks, sometimes months later. Drugs of abuse tend to have a negative effect on sleep for sometimes many weeks. And it's very frustrating. And I think that's why it's so hard sometimes to treat patients with addiction, because it impacts that sleep cycle in a way that it takes a long, it's like jet lag. So it's 10 hours time to 9 hours time difference from Los Angeles to Cairo. And if it weren't that I was able to get some naps in between, it takes a while. So sleep hygiene is very important. Try to manage stress. Try to make sure that you're relaxed before you get into bed. When you get into bed, if your mind starts going over, oh, I need to get this, I need to go to the market, tell your brain, we used to say in CE, just say, stop. I'm going to focus on breathing to try to calm things down. They used to say count sheep, right? Well, if you're counting sheep, you're not thinking about relationship problems or work problems or social problems. So the thing for sleep is tell people, sometimes it takes a while. One of the worst things for sleep is people who start taking sleep medications on and on. They stop working, really. It varies. Some people 3 days, some people longer. I've had patients say, oh, I've been taking a sleep medication for 3 years. Not good. That's a bad doctor that has them on sleep medication. We should be working on what can we do to improve sleep. So it's a very important question. We need to make sure the patients know that sleep is important for health. There are many things that affect it. What allows them to calm down and relax before they try to sleep, and to make sure that we want to work with them to try to help them improve their sleep. But it's kind of like losing weight. If you want to drop 5 kilos, it's not going to happen overnight. Cutting out a few cookies is not. Losing 5, 6, 7, 8, 10 kilos, it's going to take some time. But if you keep with it, you can lose it. Sleep it's not like suddenly you're going to go to bed and wake up refreshed. It took time to get there. You ever notice we don't need to train babies how to sleep? We don't need to do therapy. Babies know how to sleep. When they're tired, they sleep, and they sleep a lot. So I think it's a very good question, but we have to educate our patients on why it's important and help them to understand what's keeping them from being able to fall asleep.
Thank you.
Thank you all very much.
دكتور احمد هيكلمنا فاضل 45 دقيقه هيكلمنا عن الحاله بتاعته. اتفضل يا بيه.
I would like to start my presentation. Personal history of the presentation start with Mr. EGZ is a 31-year-old male Egyptian Muslim. He's single. He lives in Bashtir, Giza. He's an undergraduate at Tiba Technology Institute and works in advertising. He's a 14-pack year smoker. The source of referral
14 pack
a year يعني بياخد 14 سنة علبة واحدة سجاير.
بقاله 14 سنه.
بقاله 14 سنة سموكر.
انت سميتها 14
pack year smoker. It's yes, Americans like to call it this way. بيكتبوا السنين pack أو 2 pack أو 3 pack years smoker.
First time to know this. I thought it's 1 pack daily for the last 14 days. This is in American language is
Very common, yes. We're talking about pack years of smoke.
Okay.
Good to know this.
Source of referral
سنة قد ايه؟
سنه حاليا 31 سنة. Source of referral he's presented to our addiction outpatient clinic by himself seeking help regarding his substance use, and he asked for voluntary admission.
تمام.
The patient complained أنا جاي علشان أبطل مخدرات لأنها تعبتني نفسيا. For translation, I'm here to stop taking drugs because I feel psychologically drained. The informant's complained his mother, she lives with him and she's reliable. عاوز يبطل مخدرات ويرجع كويس.
لا عاوز ولا عاوزاه؟
عاوزاه يبطل مخدرات ويرجع كويس. I want him to stop using drugs and become a better person. History of present illness. The condition started 13 years ago with gradual onset and progressive course. When the patient was 17 years old, he started smoking tobacco under peer pressure from his friends at school. He started with 1 cigarette a day and reached to 1 pack a day. A year later, he played at Taekwondo Championship abroad, where he and his friend wanted to experience alcohol for the first time. He tried 1 shot of tequila, which he described as pleasurable experience, which felt as calming, as happy as the effect of after workout. He started with 1 shot a week and gradually increased to 2 liters a day.
Calming effect of the alcohol after the
He felt as calming
after
as
the physical sportive workout.
Yes. He gradually increased to 2 liters a day in the period of 7 months. He also tried drinking beer and vodka. He used to snuck in tequila in his taekwondo practice.
يعني اسمك
كان بيخبي البيرة في كنزات البيبسي وهو رايح التمرين وهو راجع من التمرين عشان ما حدش ياخد باله. كان بيخبيه. He started experiencing nausea, headache, body aches, and hypersomnia, which he didn't realize was withdrawal symptoms when he did not drink. He thought it was like he ate something bad at the gym. He thought he's just tired after workouts, and he didn't realize those are withdrawal symptoms. A year later, when the patient was 19 years old, he started smoking cannabis as an attempt for a new experience. He began with 2 puffs a day, reaching a maximum 5 cigarettes daily. He stated it was as rewarding as alcohol. At the age of 21, he started sniffing heroin, starting with a quarter of grams a day, gradually increasing those to 3 grams a day to achieve the same pleasuring effect. At this time, he stopped drinking and smoking hash. He switched to IV heroin while using safe injection techniques after 6 years, starting with a quarter gram a day, reaching to 1.5 grams a day in this duration of 2 months. 6 months later, he started to mix IV shots with mediaretic eye drops, tropicamide, to enhance the effect. Frequent withdrawal effects were experienced, such as fatigue and bony aches and flu-like symptoms. During this period, he suffered academic and sportive career setbacks and losing most of his savings during this active addiction period. He also struggled socially, fighting with his mother and losing his fiancée. At the age of 28, he was found unconscious, naked on the bathroom floor after overdosing. When he confessed to his family his substance use problem and decided to seek help. He was admitted voluntarily to our addiction rehabilitation unit for 90 days. He completed his program successfully. After discharge, he complied on his outpatient visits and daycare meetings for 1 year without any relapses. Later, he started to volunteer as a staff member in our addiction treatment team. After that 1 year, the patient relapsed. He returned to sniffing and injecting heroin for 6 months. He noticed becoming verbally and physically aggressive to his family. He demanded more money from his mother by bargaining her with her properties. Realizing his behavior and out of guilt, he asked for readmission. Summary of the substance he started to use. Tobacco was used at the age of 17, started as 1 cigarette and ended up as 1 pack per day over the course of 1 year. Alcohol, he started at 18 years old, 1 shot per week. After 7 months, 2 liters daily. Cannabis, started at the age of 19, 2 puffs per day. Over the course of 1 year, he became having 5 cigarettes daily.
This is a very good example of the simple Excel sheet. ساعات بنستخدمه عشان نعرف الدنيا كانت ماشيه ازاي في ال10 سنين في انواع المخدرات المختلفه اللي خدناها. شيت تاني لمرات دخول المستشفى، كل مره قعدنا 5 ايام، مره قعدنا شهرين، مره قعدنا 6 شهور، خدنا علاجات كذا. اسباب الانتكاسه، في المره الاولى لما انتكست عشان كذا، المره الثانيه كان علشان كذا، المره الثالثه عشان كذا. الماريتال ريليشنز اند سيكشوال ريليشنز، ان في السنه الفلانيه كان عمل كذا، السنه الاعلانيه كان عمل كذا. لما بنلاقي الشيت ده قصادنا بنقدر نتخيل الهيستوري بتاع المريض ماشي ازاي بطريقه كويسه، ولما بنقدمه في امتحان بتبقى الامور واضحه للاكزامنر. صوت في كذا طريقه، بس احسنهم ان احنا بنكتب ان المريض دلوقتي هو دخل المستشفى من شهرين وبقى له 4 شهور بياخد كذا وكذا وكذا. في الباست هيستوري بنحط الكلام ده. فسنة هو دلوقتي 31 سنة لما كان سنه 17 من 14 سنة يعني سنة 2001 حصل كذا وكذا، سنة 2002 2010 حصل كذا، 2012 حصل كذا، يعني دلوقتي. لكن لو هو one continuum بنكتبه as it is one continuum، لكن في دلوقتي the current status and the previous history.
He also started heroin at the age of 21 with a quarter of gram a day. In the course of 6 years, he started to have a maximum dose of 3 grams per day. Using heroin with eyedropper at the age of 26, quarter gram per day. At the course of 2 years, 1.5 grams per day in IV injection. Past history?
ايه رايك ارجع تاني كده. What's your opinion about this history of multiple drugs that he's taking?
I guess it gives us like a background about his personality traits. That he's impulsive. He seeks new and novel experiences. Sometimes he just get to do things under peer pressure and out of proving some qualities about himself sometimes.
What else?
They're all downers. They're all downers.
Depressant. This is the second thing. All are depressant substances.
Yes.
Nothing is stimulant. Number 3.
He was taking the perfect drug.
He was seeking the perfect drug.
He was taking the perfect drug that would solve all his problems.
Which one is the perfect drug?
For him, I don't know.
You mean that he's escalating the
Yes.
medications اللي بياخدهم to seek the optimum perfect drug?
Common presentation in heroin users is they start with tobacco, alcohol, and cannabis, and then progress.
This is a common march. The cigarette is the golden key for addiction. It started by 1 cigarette per day, then 1 pack a day, and then I'll try cannabis, alcohol, and he started a strong types of alcohol like tequila and whiskey, and it started hash, then it started opioids like heroin by sniffing, and this after this the injection. فهو مشي في الجولدن مارش العادي، كانش في حاجه غريبه. ايه تاني؟ What else؟
الاي دروب اللي دكتور التاثير بتاعها بيبقى سينرجيتك مثلا الهيروين ولا؟
دكتور محمد ليه بنحط اي دروبس على الهيروين في الانجكشن؟
الاي دروبس has anticholinergic action. Augment
Sometimes Egyptian addicts they mix
Pediatric eye drops.
eye drops with the heroin for the injection. Why?
Eye drops has anticholinergic action, may augment the effect of other drug abuse, affect memory, could induce hallucinations, visual or auditory, may be heavy for the patient.
What else? Number 1 is the anticholinergic side effects. Number 2, what about the clotting effect? لها أي تأثير على إنها تمنع الكلوتينج، توقفه أو تزود الكلوتينج، يعني تخلي فيه
increase clotting and maybe infected endocarditis up to cardiac arrest.
The infective endocarditis is one of the common cardiac side effects of patients that comes from the infection of the syringe. So you see the eye drops is first for anticholinergic
developing vasoconstrictive effect على الارتريز والفيسلز.
And this will avoid bleeding and anticholinergic side effect. Okay. سؤالك كان ايه على الاي دروبس؟ هل الاجابه دي شافيه لك؟
هو بس بياخدوها عشان الانتيكولوجيك افكت والاوجمنتيشن بتاع
الاوجمنتيشن بتاع الاوبيويد. تمام. تمام. في ايه هنا تاني يا جماعه؟
Background personality of the patient is anxious personality because he is taking alcohol, an anxiolytic effect, powerful anxiolytic effect.
And the opioids is an anxiolytic or antidepressant or what is it?
It makes it an anxiety depressive symptoms.
One of the best antidepressants in the world. So this sheet can tell us about the anxious depressant effect of the patients. And I'm wondering why this patient didn't use stimulants.
I would like to add, he had a very hyperactive lifestyle. He used to work out 3 or 4 times a day. He used to go to school. He had a very a high demanding, high functioning lifestyle during this time. He didn't need any stimulating effect from any drugs. He wanted to have this calming, happy, sedative effect from those drugs he used to take.
So the patient is much obsessed with this hyperactive running thoughts, running life inside. So he wants to calm down. That's why he used to have the depressant effects. Why the patient is using alcohol when he goes to the training activity? Before the training activity, when I go to my training activity, I use water. Why this gentleman used alcohol?
High stress levels.
Pardon?
High stress levels.
So using alcohol to decrease the stress of the athletic competition. Number 1. Number 2. To calm down the performance anxiety. Yes.
Social lubricant.
To calm down the social anxiety. Yes. What about the aggression? If I fight with you, I'll kill you. If I take alcohol, I'll not kill you. So this might reflect something in the personality makeup of this patient. His relation to anger and aggression. He's trying to modify his way of anger and aggression. He chose a taekwondo type of sport. It's individual fighting sports. We have individual sports and team sports. We have fighting, non-fighting. He used individual fighting sports. The aim is to kill the opponent. But I choose individual fighting sports and I don't want to kill him. I take alcohol before the competition, before the training, not after. So this may indicate something with the aggression and anger, as he told me, of his life. رجعنا كده لتاني سلايد.
هنا؟
تاني سلايد. لا اللي بعده. What's this? This is his mother will. It's not my will. So my mother will is to stop taking substances. This is normal. But how this is be put in the dynamics of this patient? How do you relate this to the stress?
Like he has a demand,
Controlling
like he has to put demand
pleasing
on someone else.
Like
It's not, it's
قولي
not-
بالعربي كده.
يعني حد هو اللي عاوزه فهو مش جاي من نفسه فحاسس ان ده مطلوب منه اكتر ما هو عاوز يعمل كده.
تمام. Am I ruling my life or my mother is ruling my life? Maybe she's choosing my career of sports, my career of studying, my when to stop taking alcohol, and this will reflect us to the anger and aggression which is repressed or depressed. So I have to investigate this area with a relation to the mother. Where is the father?
He died.
He died at the age of
11.
11.
When the patient was 11.
رجعني تاني للشيت بتاع When my father dies at the age of 11, is it an alternative scenario at the age of 17 to compensate the death of my father? How?
He started to work.
هتنزل لي راسك بس مش هعديها.
لا.
هتقول لي السبب هقول لك تمام.
His family, he was the youngest of his siblings, and he at the age of 10, his mother started to ask him to start working at her workshop, and started collecting money and cooking ready meals to sell. He started to have his own income at a very young age to support his family. He also had a very prominent sportive career. He started traveling abroad.
Full stop. So when I do this at the age of 12, 13, 14, so who will be my parent? Myself. First, I'll be my parent, the parent of myself. And maybe I'll exclude the child ego state. And I'll magnify the parent ego state. And this was happened at the age of 11 after the death of my father. And I was the youngest sibling. Age of 11, 12, 13, 14, 15, 16. At the age of 17, I cannot tolerate this ego state. So I need another child ego state. So I choose substance to compensate things that happen to me. Is it a good story? 50-50. I put an احتمال, possibility, and I have to search for this. And when you said this is a complaint of the mother and عاوزاه يبطل, oh, I asked myself, where's the father? And the father died at the age of 11. Okay? احنا بنحط احتمالات. We put possibilities of the running causes for the addiction. It's a psycho-bio-social spiritual causes. And when I have something موجود, something not present, I have to ask why. And a good doctor is a good observer. And then try to search, is it a good scenario for this patient or not?
The patient is dependent on his mother. He may had dependent personality disorder, also anxious personality disorder. Cluster C should be further investigated.
Good. دكتور محمد بيقول لنا احنا بنحط axis 1 the diagnosis, axis 2 the personality, وبنسيرش. This according to DSM-4. There is no axis 2 in the DSM-5 or DSM-5 TR. But when I treat addiction, there is no illness called addiction. Addiction is a symptom. I treat the personality. I treat the dual diagnosis, the bipolar, the schizophrenia, the panic attacks, the whatever. So now Dr. Muhammad is putting us a possibility of avoidant, dependent personality. Dr. Ahmed, what's the personality of your patient?
He is a highly competitive sportsman. He wants he thinks about himself in a very high demand. He should be achieving high in every competition he competes in. And his mother is also a very high demanding personality. She wants him to see him as a very successful person, a very talented sportsman. So this is one of the causes that causes him to start addiction, and this is one of the causes what causes him to start to relapse again, because he always have this image about himself that he needs to be a superhero, to be a championship, and this is what also put a large and a huge stress on himself, and it's disabling his capabilities, and it makes him fail very much in every trial of treatment, in every trial of taking any sportsman championship. This is why.
So you don't put him as an avoid independent.
No.
What personality, type of personality?
He's an extrovert. He's an extrovert. He knows how to deal with.
There is no personality called extrovert. It's a trait, which could be under paranoid, under narcissistic. What the type of personality? What's in the sheet? What's personality in the personality before the illness and the personality now? It's part of the sheet. What do you put him?
He was almost as obsessive as a perfectionist before the disease started, and now he's somehow dependent on his mother and on his family.
I think the mother repeated she wanted to be, not the patient wanted to. يعني this is confirmed that the patient independent.
بالعربي.
Yes. الأم عايزاه يبقى كذا، الأم عايزاه يبقى كذا. هو مش عارف هو عايز يبقى إيه. This is confirmed that the patient dependent on his.
You agree with this?
Mother. Yes.
Currently, yes.
So, how this is reflected in a management plan?
In management plan, we try to put a structure for this family to work on. We try to educate the mother about the role of the patient and how he should be treated in the community. She should not ask him for high demanding milestones. She should ask him for the bare minimum to achieve, and so on. We can build on more progressive lifestyle in his work, in his career, with, getting married, stuff like this.
Good. كمل. شفتوا يا جماعة طريقة التفكير؟ الواحد بيحاول يخش منين لفين ويحاول يجمع معلومات علشان نعرف السيناريو كان ماشي ازاي، وان الراجل ده لو خرج لنفس ال previous makeup or situation he will go back to the same results. And that's why he was a counselor of addiction for 1 year and then he relapsed. لأن كان لسه في ثغرة في البرسوناليتي وفي الاستراكشر بتاع الفاميلي ما اتحلتش. That's why he relapsed. وممكن يقعد معانا سنة سنتين. لا قدر الله he get relapsed لو ما فهمناش الاستراكشر ماشي ازاي. For the history that we made, how would be your relation to this patient concerning his parents?
يعني قصد حضرتك هنعمل ايه للاهل؟ احنا
you do dynamic psychotherapy?
لا. But what I did to this patient is I asked the mother to come for a session, and we talked about what are the limitation of his disease, and she must accept that he has some limitations due to his illness of addiction, and she should give him the space and the time to heal, and give him the time to speak and to ventilate all his bad emotion and all his bad experience for him to be cooperative and to be within our reach all the time with our outpatient clinic and our daycare team, and soon we will want her to start motivating him for different approaches in his therapy. But for now on, we want him to for the mother to give him like a good time, good relax, good break, just for him to start analyzing and feeling how he should be dealing with his.
Good. Our management plan will be a relapse prevention program, matrix and outpatient.
Yes.
Group of matrix, CBT or DBT if we find any traits. It will not be, I'm not concentrating or focusing on the dynamic psychotherapy, but maybe here in Abbasiyya, there may be advice for assisted medication therapy. This would take methadone or something for life. Whatever the plan, you will see the patient once a week for dynamic psychotherapy to see him. How do you see the transference that this patient will make with you? He will consider you the new father. And he will consider you the mother that who is not intruding his life. We are fathers or mothers of the patient sometimes. We are a substitute for the neglecting parents, sometimes of the neglecting husband in the dynamic psychotherapy. That's why the transference will emerge. We still have 10 minutes.
Past history, there's no past psychotic disorder, no
Positive death.
Fine. In medical history, at the age of 2, the patient had a burn accident disfiguring his face and neck with severe painful disfiguring complication. He underwent multiple surgeries, plastic surgeries or corrective surgeries until the age of 16. Family history, there is substance use disorder at his father's brother and his cousins. No other psychiatric disorders. The mother has a systemic lupus diagnosis. He lives with his
كان
mother.
سنة كام؟
35.
كان الأب عايش ولا جوزها كان عايش ولا ميت؟
أعتقد بعد وفاة الأب.
في علاقة؟
Stress.
What is systemic lupus?
Autoimmune disease caused mainly by stress.
Maybe she's prone to systemic lupus, but it starts to happen when the husband dies. The immunity comes down due to the stress of I have many children and I have so and so, and the systemic lupus starts to arrive. What that stress makes in our lives? The stress, chronic stress, make us having a high level of cortisol or adrenaline. When I see a car coming to hit me, the cortisol and adrenaline goes to very higher levels. So I start to having the fight or flight attitude. I jump or I run away like I'm playing. I run away. أجري بسرعة أكتر من أي واحد بيجري في الدنيا. انتهى الموقف. The cortisol and adrenaline goes down. But if I am in chronic stress, this will be elevated for long, and this will decrease the immunity. So what comes to me? Systemic lupus, thyroid illness, diabetes, fibromyalgia, MS, or cancer. Sometimes cancer is considered one of the autoimmune disease. And the autoimmune disease starts with this young lady at the age of 35 when the father dies 20 years ago.
I want to ask about the past history of a severe burn. Is it can be a risk factor? Can be like something, this chronic stress of painful condition and disfiguring condition can cause?
When you ask the patient about this, what was his answer? Was it a big trauma? Was he concerned about the disfigurement? Was it in the face, in the hidden area? Did he rely too much on his features and facial features, or he didn't care at all of his beautiness? And
for him, it was a big issue at that time during his teenager years, and the pain, the frequent surgeries was a big issue. He used to get abstinence a lot from his.
Does he have now a PTSD symptoms according to this?
No.
Did you ask about this?
Yes. No.
Did you put it in the sheet?
Yes.
Because an examiner will see if you put it or not, then you'll have a good point. So the first trauma was the death of the father at the age of 11, and the second trauma was the birth.
Yes, at the age
Any
of 2.
previous traumas before the age of 11?
At the age of 2, he had that burn accident.
Age of 2?
Yes, he was a child.
Between 2 and 11, any abuse, any sexual harassment, any?
No.
Good. Why do we ask about sexual harassment or sexual abuse for early age. What's the relation to drug addiction?
Alcohol-induced sexual behavior and aggressiveness, assaultiveness.
Now, after he took alcohol?
Oh, after his...
No, I'm asking, why do we ask about sexual history of harassment or rape before the age of 17, before the start of intake of alcohol and drugs?
It's possible because it's common in personality disorders that they have a background, and also in patients with substance use disorders that they have this presentation.
Why? التروما بتعمل ايه في الشخصية؟ Which type of personality? Borderline. It's some sort of splitting, some sort of dissociation, some sort of severe anxiety and impulsiveness and fear of abandonment and much disturbance. So I want to calm down all this mess. How can I calm it down? By drugs.
يعني في داتا كده في البيشنت ان هو بيسرق بيمالسف بيعمل مشاكل حاجات اللي هي السيمتومز بتاعت الانتي سوشيال بيرسوناليتي تمام. بس بعد كده لما بيتعالج السيمتومز دي بتروح يرجع ياخد مخدرات تاني السيمتومز دي بترجع. هل دي كده تكون بيرسوناليتي ديسوردر كانتي سوشيال او حتى
It's a loop. The antisocial behavior brings me to start the addiction, and when I become an addict, I start to have an antisocial behavior. It's a loop. What comes first? You cannot tell exactly.
behavior or disorder?
Disorder, of course. Usually disorder. You see it in this patient? You see it in this patient? Where?
كان بيسرق وبيضيع فلوس ويعمل مشاكل كتير مع والدته.
Is he an antisocial? نعم. To buy the substance. She is telling to buy. أنت اسمك بيسان؟ افتكر. Maybe to buy the substance.
يعني مش هنعتبرها symptoms of personality.
لا ده موضوع كبير هو بس مش وقت دلوقتي مع العيان ده هو
هنشوف الديورينج يعني من زمان ولا فات والصفات الشخصيه هاي من الادolescence تفضل حد هيك ولا هي بتيجي وقت بس معين الموضوع.
طب انا عايزك تجاوب على دي. هو لما بياخد عنده antisocial behavior ابتدى ياخد مخدرات بعد ما خد مخدرات it's the same pattern of antisocial behavior or so the same pattern is his previous personality increased due to effect of alcohol or drugs. What's the data? We still have 7 minutes.
Personality traits, he was extrovert, had many friends, both genders, impulsive, anxious, with emotional instability, reacting to stress by acting out, religious but not practicing, hobbies, playing different types of sports, and he likes to cook. Relationships, one romantic relationship with a girl from his taekwondo practice, which failed by the way. Schooling, he was...
ارجع تاني. According to these personality traits, تحت بكتب my impression. So, which personality is? Borderline?
It is not a disorder, it's just personality traits, right?
Borderline traits?
Oh.
So we have borderline personality disorder, we have borderline traits. What else? Narcissistic? Could be a very good personality. Very احتمال يعني احتمال.
Possibility.
It's a very good possibility that he is narcissistic. The outgoing, the extrovert, the impulsive, the feel of I'm different by the taekwondo. It's could be narcissistic. What else? And social. ايه مش انت بتاع الانسوشيال؟
ده باتر في كل المرضى.
يبقى ده موجود، يبقى ترفع ايدك وتقول انسوشيال. ما تخافش. انت رايك انسوشيال؟
لا انا عارف المريض ده
مش انسوشيال، يبقى مش كل المرضى. امال ده ايه؟
هي دي هي كوموربيد مع
الراجل ده which type personality؟
ممكن يكون كلاستر بي.
كلاستر بي and social, narcissistic, histrionic, borderline, and social. Which type?
borderline.
He is borderline. تمام. لا هو شرط يبقى personality traits لكن مش شرط. It's not a law to be a personality disorder, but it should be a personality trait. He's an addict. The problem with addiction makes some. اتفضل.
schooling البيشنت ستارت.
لا بوزيتيف داتا.
طيب الاوكيبيشن بتاعه ابتدى في ال10 سنين ابتدى يشتغل مع مامته في المكتبه، وفي 17 سنه ابتدى يدرب تايكوندو، و19 سنه ابتدى يشتغل في الدعايه والاعلان، و29 سنه كان بيشتغل معانا فولنتير في المستشفى.
Diagnosis.
Physical examination, risk assessment, diagnosis. Opioid use disorder, mainly heroin, severe in early remission in controlled environment.
Very good. Differential diagnosis. مفيش حاجة في الدنيا اسمها diagnosis. في حاجة دايما اسمها differential diagnosis.
He could be
Is he sexual perversion? No. Is he an anxiety? Generalized anxiety disorder?
comorbid with a substance.
Number one, plus polysubstance abuse. And you put the JAD number one, and you'll defend on this in front of the examiner. Why you put it as number one?
Because it seems that all of his substance use was just meant to calm down his anxiety or give him an extra edge in social situations.
What is the anxiety symptoms in the sheet? Okay, what you are telling is put it number two as a differential diagnosis, and you are telling us about the formulation of the case, that an anxiety makes him to do so and so and so. It's related to the formulation and to understanding and to the dynamic of the patients, not as a main diagnosis, because there is no anxiety symptoms in the sheet. في differential diagnosis؟ نعم. مين بيقول borderline؟ Borderline personality disorder. What are the symptoms of borderline in this patient in the sheet? And if it is there, you put it as first diagnosis plus substance use, or you don't see substance use as an illness. انت شايفه ان هو يتشخص borderline الاول ومعاه substance use ولا ما فيش substance use؟ في الديفرنشال borderline لوحدها هتقولي borderline ولا بلس؟ احنا من حقنا في ال DSM-5 احنا نقول border substance use plus borderline plus eating disorder plus agoraphobia. من حقك تقولي بلس حاجات كتير. فانت لو هتحطي البوردر لاين هتقولي ان ده the only differential diagnosis هو عنده بوردر لاين بس ولا الراجل ده مدمن كمان؟ مدمن. يبقى هتقولي بوردر لاين بلس سبستنس يوز. تمام؟ فانت بتحطي قيمه اكتر للبوردر لاين.
trauma related stressors between brackets PTSD associated with substance use disorder.
What are the PTSD symptoms here?
Need more investigation and assessment.
He's a schizophrenic and he needs more investigation. تفكير سليم لكن تطبيقه عشان تقنع الاكزامينر to convince the examiner is a bit difficult. So when we put opioid, polysubstance number one, borderline number two, and you tell the examiner, I leave 3 and 4 and 5 silent and I put PTSDs number 10. So it's far away and it's very weak to diagnose. And it needs further information from the family and from the patient. But if the PTSD symptoms, we ask Dr. Ahmed to search for it for the next meeting.
هو ليه ما نجيبش سيرة اللي كان في مثلا depression symptoms قبل أول مثلا أول مرة ياخد
سؤال وجيه جدا. ليه ما فيش أعراض اكتئاب هنا؟ وهل لو موجودة عند المريض الدكتور أحمد سألها ولا لا؟ جاوب يا فالح.
احنا سالنا دكتور ما كانش اي ديبريسيف سيمبتومز او يعني عامله اي مال فانكشننج او عامله اي مشكله في حياته قبل الفتره بتاعت الادكشن.
شفت يا فالحه بقى هو جاوب على السؤال وما كانش فيه ديبريسيف سيمبتوم بس ايه سال. فاحنا بنقول في الشيت جايزه انا عديتها بسرعه. And we ask about depressive symptoms, anxious symptoms, sleep disorder, كذا كذا كذا. طبعا سؤال مهم جدا.
Say masked by substance. Masked by substance.
وما فيش يوم من غير substance. From the age of 17 till the age of 31 except 1 year. هو ده بقى اللي كان عايز منك investigations جامده جدا يا دكتور احمد. This 1 year of sobriety. Sobriety. This 1 year of sobriety, I should investigate everything carefully. قد ايه كان في depressive symptoms؟ قد ايه كان في relation to others؟ كان بيلعب رياضة تايكوندو ولا دكتور؟ كان بيفكر في المخدرات، كان عنده PTSD symptoms، كان عنده sleep disturbance، كان عنده السنة دي اللي مبطل المخدرات بتعمل لي ماسكينج على كل السيمبتومز. فالسنه دي مفيش مخدرات فمفيش ماسكينج. فكان الوضع عامل ازاي؟ السنه دي اخبارها ايه؟
في السنه دي هو كان ملتزم جدا بالاوت بيشنت كلينيك وبالدي كير ميتنجز. كان كل الفيدباك اللي كان بيتعمل عنه ان هو كان فيري بروجريسيف في الثيرابي بتاعته، كان فيري كومبلاينت على الستاف اوردرز اللي كانت بتجيله، وكان فيري ديديكيتد لكده. ما كانش فيه اي ديبريسيف سيمبتومز او ديبريسيف ابيسودز في الوقت ده. كان الريليشن شيب between him and his other patients كانت كويسه جدا، ما كانش بيحصل اي مشاكل. لما بقى كمان بعدها بسنه ابتدى يشتغل فولنتير معانا في المستشفى as an ex addict. كان كويس جدا، كان very helpful، كان very كان ملتزم جدا بكل التعليمات اللي كانت.
شفته على مدار سنه.
انا ما كنتش موجود في المستشفى في الوقت ده، ولكن رجعت لكل الاكس ادكتس اللي كانوا اشتغلوا معايا كانوا بيشكروا فيه جدا وكانت الدنيا تمام.
What was his program of being sober in this year?
كان شغال 3 ايام في المستشفى as an ex addict، والاربع ايام تانيين كان بيشتغل في الدعايه والاعلان في مكتب مع حد من زمايله القدام اللي ما كانش ليه اي علاقه بالمخدرات.
This is not a relapse prevention program. This is a relapsing program. Is to work too hard 7 days a week. An ex-addict is an addict, but in a sober state. So don't put in his shoulders too much effort. In this year, was he taking his medications as an antidepressant?
Yes.
Was he going to his doctor once every 2 weeks? Was he talking to his supervisor from the NA? Did he completed his 12 steps? Did he attend the 12 steps meeting regularly, once or twice a week? If he is in a relapse, addicts should continue 90 meetings in 90 days. When I have some addicts in crisis, oh, Ahmed, please make me 90 meetings in 90 days, or make me 30 in 30, or make me 7 in 7. Go to the addicts and be close to them so that the crisis will fade away, and do this and this and this and this. فالراجل ده كان بيعمل حاجة عكس انه يبطل مخدرات. خلاص انا بطلت وبقيت اشتغل معالج في مستشفى العباسية ومعايا كارت بيقول ان انا معالج وبشتغل في الادفرتايزنج 3 days a week and I'm addiction counselor 4 days a week. I'm sober and he relapsed 1 year after. This is a relapsing program, not anti-relapsing program. The work should be جراديوال، يعني لازم الواحد يشيل على قد عضلاته. الادكت عضلاته ضعيفه for 1 or 2 or 3 weeks، لازم كنت اتمم على البرنامج بتاعه ماشي ازاي. فلازم افهم ال ايه، فلازم اقعد مع الاكس ادكتس، لازم اعرف يعني ايه سوبرفايزر وسوبرفايزي، اعرف هو العيان وهو بيكتب خطوه رابعه when he writes the 4th step of the 12 steps it's very difficult and they relapse on it 50%. لازم اعرف هو بيكتب خطوه رابعه حياته متوقفه عشان يعرف يكتب خطوه رابعه، ولا الدنيا ماشيه ازاي، بياخد ادويته ولا لا، عامل ايه في الماريتال ريليشن، البنت اللي حبها من التايكوندو دي مطلعه عينه، ولا the lady that he knows from the taekwondo team, is she soothing him or she is putting more stress on him. فده البرنامج بتاع الفولو اب مع المرضى دول عشان ما يقعش مني، لانه لو وقع مني what's the hazard of the big hazard of a relapse after 1 year? One hazard. Very good, very smart. I'm sober. And I think that I used to take 1 gram every day. So today I'll take 1 gram. But today 1 gram is 10 grams. Overdose. تمام؟
هو حسب الهيستوري انه هو المريض يكون دايما حابب ينجح في الخطوات وياخد يعني والدته نفس الحاجه كانت دايما مصدره يعني هو لازم يبقى كده وهي نفسها يعني ممكن حتى في السنه دي اللي بطلت فيها انه يكون المريض اصلا يعني بالنسبه للبرسوناليتي ريجكتد انه مهما عمل مش حاسس انه عامل حاجه، فهو عامل الحاجات دي كلها عشان يحس الاحساس اللي جواه ان انا مش عامل حاجه والسيلف ستيم يعني.
دكتوره بيسان بتعلمنا حاجه ان هات لنا بيرسوناليتي personality. This extrovert, impulsive, anxious, not very well to react to stress, playing sports, is very prone to relapse, and he's very ambitious to make the needs of himself and the needs of his mother, and this will make a relapse. So ask him to calm down. فاضل سؤالين.
What is the current medication of the patient?
Please.
بياخد سيتالوبرام وبياخد كوتايبين، بياخد سيتالوبرام 1 tablet at the morning وكوتايبين 200 milligrams at the evening.
1 tablet of Celexa or citalopram will compensate the 2 grams of heroin. ما نزودش الجرعه ليه؟ نزود الجرعه لان حجم الديبرشن والانكزايتي عند المريض ده عالي. الايسيتالوبرام is better than citalopram. Venlafaxine or duloxetine is better than citalopram. 3 tablets is better than 1 tablet. Adding a very mild dose of antipsychotic, even fluphenazine 1 milligram, aripiprazole half tablet of 5 milligram. This will be good. Is the bipolarity in this patient, and I should rely on carbamazepine, a small dose of sodium valproate? I have to think of all of this. So the management is medication, short hospitalization, rehabilitation, so and so. What else?
Currently, we're trying to work out with him as in
No.
using exercises.
No. Okay, the 6 pillars is the exercise, but I'm asking about where is the family therapy? Where is the therapy to the mother? Where is it? Okay, this is a very good investigation. Drug screen, CBC, negative virology. What else I'm always asking about? Psychometry.
It's there.
لا ما كتبوش لا. Scale 2, addiction severity index. Beck or Hamilton depressive scale to see or an anxiety scale to see the degree of anxiety or depression. الراجل ده skip 2 to know the traits or which type of personality traits or a very good sheet. Thank you, Dr. Ahmed. Follow him up. Make a homework to me and send it by the WhatsApp. What's the strategy for relapse prevention in the context of knowing all the information that your colleagues have told you, the mother, the 12 steps, the narcissistic or whatever personality. You do the skit 2 and tell me the result.